serious about that, because it's when you let your best go, they come back. Look at India. They come back. Nobody has paid me to come back here. Nobody's paying me to come spend part of my time in Nigeria. It's just a natural thing. Not everybody will come back, but majority will come back. And when you come back with something.
Wow. Sir Winston Leonard Spencer Churchill was a British statesman, soldier, and writer. He once said, "Healthy citizens are the greatest asset any country can have." Absolutely spot on. My next one is from Thomas Fuller, who is a British scholar and preacher. He once said, "Health is not valued till sickness comes." I agree too. My next quote is from Kevin Allen Lee, who is an award-winning author, life wellness coach. He once said, "In my opinion, our healthcare system has failed when a doctor fails to treat an illness that is treatable." Very good one. My next quote is from Howard Zinn, an American historian, playwright, philosopher. Once said, "Give people what they need: food, medicine, clean air, pure water, trees and grass, pleasant homes to live in, some hours of work, more hours of leisure. Don't ask who deserves it. Every human being deserves it. Every human being deserves the good things of life." Dennis Kucinich, who is an American politician, also said, "Everyone should have health insurance. I say everyone should have health care." I'm not selling insurance. Of course, why does it look like he's selling health insurance? Let's see how this could relate to what we'll be discussing today. Very warm greetings and welcome to The Conversation. We are reaching you from KAFTAN's television studio here in the nation's capital of Abuja. Of course, I am Annabelle Ojin. Now, the Nigerian healthcare industry is facing challenges associated with outbound medical tourism, deteriorating medical infrastructure, low government budget allocation, and poor compensation, and also subsequent emigration of skilled healthcare workers. Healthcare infrastructure in Nigeria is still underdeveloped and lacks modern medical facilities. The country's healthcare indicators are some of the worst in Africa, even though I hate to say it. It has the fastest growing population globally, with 5.5 live births per woman and a population growth rate of 3.2 annually. It is estimated to reach 400 million people by 2050, becoming the world's third most populous country. Medical professionals are in short supply, with only about 35,000 doctors, despite needing 237,000 according to WHO figures, partially due to the massive migration of healthcare workers overseas. Nigeria loses at least 2 billion every year to medical tourism, according to the Nigerian Medical Association, NMA, and India accounts for more than half of this outflow. Now, the pandemic also helped highlight the need for significant investment in the healthcare sector to reverse this trend and ensure access to health for all Nigerians. The coordinating Minister of Health and Social Welfare, Professor Ali Pate, and the Minister of State, Dr. Tunji Alausa, have unveiled a 4-point agenda that will ensure that the sector delivered improved healthcare to Nigerians. They said that they would deliver the mandate in 4 main areas, namely improving the governance of health, population health outcomes, medical industrialization, as well as value chain, and improving health security. Professor Ali Pate said their work was geared towards saving lives, reducing pain, and producing health. He said, and quote, "It is time for renewal. It is also a time for optimism, given what we know has happened in the past." And he further stated that looking forward, there is a lot of potential for improvement in terms of where we can go going forward for Nigerian citizens to live better and healthier. End of quote. Dr. Asekhame Isemede is an NHS consultant specialist, advisor at Care Quality Commission, that's a CQC, England, a member of the International Society for Quality in Healthcare, and Director, Patient Safety Africa. and he's my guest. So you will get to meet my guest after this report on patient safety put together by KAFTAN TV's correspondent Ben Uku, and I will see you later. Welcome to The Conversation. Evidence have shown that patient engagement reduces healthcare errors, cost, and improves healthcare delivery. Active participation of patients in their healthcare decisions has been recognized as a key factor in improving overall health outcomes. The Nigerian government, in collaboration with World Health Organization, commemorated this year's World Patient Safety Day with a call to ensuring that patient voices are heard and their concerns promptly addressed. Speaking at the press briefing today in Abuja, the Permanent Secretary, Ministry of Health and Social Welfare, Kacholum Daju, said with the renewed hope agenda of the current administration, efforts are being made on improving the quality of health governance, medical industrialization, and health security.
I am delighted to inform you that the Federal Ministry of Health is developing the first ever national policy and implementation strategy on patient safety and care quality, alongside our relevant stakeholders, with WHO leading. And this was sent to stakeholders on Thursday and Friday last week for a review and validation. This is being done in line with Resolution 18 of the 55th World Health Assembly, which called for member states to recognize the burden of patient safety and to set up policies to manage them. This National Patient Safety and Care Quality Policy, when finalized, will focus on improving patient and family engagement in healthcare, medication safety, surgical safety, infection prevention and control, safety of all medical procedures, etc. It is my hope that health facilities at all levels will adopt and implement this policy.
The World Health Organization's call to elevate the voice of patients emphasizes the importance of improving patients in policy, formulation, governance structures, safety strategies, and their own care. The Deputy WHO representative to Nigeria, Alexander Chimbaru, emphasized the need to scale up efforts to build and strengthen quality, people-centered, sustainable, and resilient health systems.
Let me start by congratulating the country for commencing the process of developing a national quality policy and strategy, which is actually ongoing right now. Big congratulations to the country. Policies are developed, but implementation becomes a challenge. That's an area I'm actually confident with the new dispensation that this is going to take place and shall happen. We shall protect our patients. It is crucial to fully commit to implement the WHO Global Patient Safety Call and accelerate our necessary actions to raise patient voices in this World Patient Safety Day. I would like to conclude by calling on Nigeria to heed the call by our RRD to work together with other WHO member states to raise awareness, provide platforms for patient concerns, share initiatives and best practices, and take action to reduce avoidable harm.
Also speaking, the Director, Patient Safety Africa, Professor Asekhame Isemede, emphasized the key role the national policy will play and the need to develop savvy care in every healthcare center.
We know about the Patient Bill of Rights. Patient Bill of Rights, number 12, says you have a right to make complaints. And when I scrutinized this, I found out that, yes, this is good. But actually what patients are looking for is not the right to make complaints, the right for their complaint to be heard and responded to appropriately. Moreover, not every patient is able to make a complaint. We have to be aware of those who are vulnerable. So I am discussing with the Federal Ministry of Health about a concept of civic care.
The theme for this year, Engaging Patients for Patient Safety, emphasizes the vital role patients, their families, and caregivers play in the safety of healthcare delivery. Nigerian government and World Health Organization said that they are committed towards a world in which no patient is harmed in healthcare and everyone receives self-care every time, everywhere. Welcome back. If you just joined us, this is The Conversation. We are reaching you from KAFTAN's television studio here in the nation's capital, Abuja. Now we'll go straight to our conversation for today. My guest on the show today is Professor Asekhame Isemede, who is Director of Patient Safety Africa. It is great to have you on the show today again, sir.
Thank you for having me, Annabelle.
Great. All right, now let's talk about World Patient Safety Day. We know that we've taken the report, and two of our correspondents took some of the footages with regards to World Patient Safety Day and what your organization is doing in collaboration with the ministry. Now let's talk about World Patient Safety Day. Knowing that you are the director of Patient Safety Africa, how far would you actually say that we're hitting the right spot? We've been commemorating World Patient Safety Day over time. What makes 2023 World Patient Safety Day different from every other one?
Thank you very much. World Patient Safety Day was set up by Resolution 18 at the 55th World Health Assembly in 2002. Okay. Actually, the World Patient Safety Day was set up in 2019 by the 6th resolutions in 2019. But the first call for the recognition of patient safety as a major issue was far back in 2002. Okay, so your question is, what will this do differently? You've heard about patient safety, you've heard about a lot of days and celebrations in the past. There's something special about this year. Okay, I would just recall, yes, the World Patient Safety Day is a day where we raise awareness on the issue of patient safety globally. Of course, starting with our community, which is here in Nigeria, that the burden of harm on patient is still too high. One too many. And of course, we're talking about thousands here. Okay. In 2002, the World Health Assembly, under Resolution 18, asked all UN nations to consider the issue of patient safety because there was a huge problem. And that's where it was. And nothing much really happened in majority of the countries. And that's why you're questioning what's going to be different. What has happened in 2019, Resolution 6 of the 72nd World Health Assembly, was that this was not just calling for recognition, it was calling for action. And not only action, a plan was set up for countries to modify, and implementation strategy was also there. So there's something completely new. And the federal government of Nigeria, for the first time, has, developed a national patient safety and care quality policy and a strategy document following the guidance of the World Health Organization. So we believe this is going to make a difference because people are not just going to talk about it this time. We're going to do something about it in order to see a difference. Thank you.
So what exactly is World Patient Safety Day? What exactly is Patient Safety Africa? What is this collaboration you're having with Nigeria? And is it only for Nigeria, or since you're representing Africa, which other country is on call here?
Right, okay, so we're Africa-wide organization, but obviously our starting point is Nigeria and the largest number of members we have within here in Nigeria. Our job is to support the government in setting up a framework that look at procedures, protocols, environment, a culture of care that we consistently and sustainably reduce harm, and where it occurs, to improve the chances of taking care of those patients. That's basically what patient safety is about. So we work, first of all, we're doing the policy, we're going to go on, we're doing the strategy document, and then we're going to go on with the implementation, making sure that it really happens where it's needed at the health facility level, and also training staff, supporting the staff. At the same time, we want to empower the public. And that is what we're doing today. Today is special because we are putting the patient at the very center of care. We say, we've heard you very loud and clear. We want you to be a co-planner. So co-design and co-development of policies. And this is what we have done in the last 10 months in the country, getting patients to be a part of the design process for the policy.
So how far so far? How far is that coming along for you? Because I know that this year's theme is engaging patient for patient safety.
Engaging patients for patient safety, elevating the voices of patients. We want to hear from patients, and we have a compendium of the feedback. People call it complaint. We prefer to call it feedback, because when you say complaint, connotes something negative. So their feedback, what they feel about the services they have been given, and then the idea is we analyze this in order to learn from it.
Okay. All right. So I hear you say implementation. Aside the talks you monitored right. Implementation. Yeah. So who is monitoring? Because that's one thing people will tell you about. It's okay to have plans. It's okay to roll out plans, and your problem always starts with monitoring. That's right. So who exactly is at the forefront with regards to monitoring that all of these plans and projects are being implemented?
Excellent question. There is a proposal in place to have a robust, independent regulator of care quality and patient safety in Nigeria. The initial document was submitted as far back as 2015, but things have not really moved. Okay. We've represented that document, and we're really pleased to let you know, and the public, that this new government is looking at that with a lot of seriousness. That, we need a number of things in the mix of solutions here. We need to support doctors, nurses, and healthcare workers. We also need to empower the patient or the general public, through instruments like, the duty of candor. It could actually become statutory duty of candor. And then we had the patient charter. Okay. Okay. And as well, you need to have an independent regulator, so that people that consistently do not want to follow the rules, they are made accountable. Except you have this combination, I agree with you, it will not work. And that was the situation in the past. I'm optimistic going forward. Things are changing. There's maturity of judgment in high levels about these mix of solutions.
Great. That's actually great to know. Okay, because I hear you talk about this new government. You talked about the ministry and how much they are driving towards change. I understand that few days ago we saw the report coming from the Ministry of Health saying that they're seeking to reverse the trend of harm to patients through a 4-point agenda. Now, kindly speak to us on these 4-point agenda. Would you actually regard them as putting our best foot forward, and what makes them different from every other agenda that the federal government has collectively come up with, the Vision 2020 and the 8-point agenda, and or even the Vision 2050? What makes 4-point agenda of the Federal Ministry of Health different?
Thank you very much for that question. I have to say, with due respect to all those who have labored very hard for the federal government of Nigeria, a lot of the national documents we have, many of them are in libraries and archives. They are solid, beautiful, well-prepared documents. The problem has always been they fail at implementation. And that's what this government wants to do differently. Okay, I'll go back to the 4-point agenda of the new government in the country, especially with the in terms of healthcare. It talks about improving quality through a robust clinical governance system. I just run through them. Improving population health outcomes. Talks about the value chain, and it talks about health security, pre-pandemic preparedness. It's very important to talk about. Everybody knows about the need for immunization. Prevention is better than cure, everyone says. To which I also add, when we talk about care quality, patient safety and care quality, it should not be seen as an optional extra for Africans or for Nigerians. People think it's going to be too expensive. But I tell you that when you build quality into your health system, you make it more resilient. And therefore, when you have another pandemic in the future, you would have the benefit. The reason why we were very successful last time was because we've been we had experiences from COVID. We had the COVID Protection and Prevention Act very quickly, and the government had to move really quickly in implementing this. So yeah, quality is an insurance against future problems. It shouldn't be an optional extra. It's actually best value for money.
Okay.
So pre-pandemic preparedness, health security requires quality in order for it to work. And the other one is improving population health outcomes. And that's really great. And I'm not surprised, Professor Ali Pate, Global Health Professor. You see, one thing he's going to do here is that for the first time, we're going to make sure that we're not quoting data from New York, from Geneva. Why is an obstetrician in Benin City quoting data about maternal mortality from the village 5 miles away? Okay? Quoting the data from New York.
From New York.
What we want to do is to make sure we generate data. The reason is what you cannot classify, you cannot improve. What you cannot measure, you cannot improve.
So that means you're measuring that data from
yes,
local, grassroots.
Local data.
Okay.
So Professor Pate is going to mandate people to ensure that they get the data. It's not just what we think and estimated things. So the data will be there. You have an input, you have a process, and it's an outcome. You collect this data and then feed back into the system for continuous quality improvement. That's what it means. And that's what we're going to implement on the ground. In the value chain, we shall be calling for other parties like the private sector. We use a huge economies of scale to be able to get to procurement, to be able to get equipment and to have a lot of things manufactured right here in Nigeria. There's no need for medical directors, 1, 2, or 3, traveling to Germany, to China to buy 5 pieces of equipment. We can get the Chinese to come in here, look at what we've, what we want to buy 50 of this. But we need you to have a station right here in Nigeria for the maintenance. And that will create job. So this is what the new government is doing. And
does this also touch on, so that I had to butt in, does this also touch on vaccine development? Because now people keep complaining that why do we always go cap in hand to look for vaccine? Why can't we generate ours here when we have all the instruments to do so?
Thank you very much about that question. It's not... You got to be very careful. So the technology required for production of certain things are very, very, they're very sophisticated. And it takes some time to go through that process, and you cannot set it up overnight. So I would be very wary about anybody telling you we're going to do it overnight in 6 months, in 1 year. It's okay as a strategy, something that can happen. I believe it will happen, but I don't want to promise that that will happen immediately because it requires a whole lot of process. You want to make sure it's absolutely right. You cannot afford to have a second-class vaccine. And so even the water that these factories will use is a special level water. And this,
All right, so now, I'm going to ask you personally. Let's go personal here, Professor Sonny. Do you actually agree that these 4-point agenda that you've reeled out, are they a step in the right direction, and also that the current minister will be able to carry out these 4-point agenda and will not have people who would keep hampering or trying to frustrate his effort like we've seen in recent times? Because it's actually one thing to be willing to make a change, and then it's another kettle of fish entirely to be able to make that change.
All right, thank you very much. Very good question. We have a new president, and we know this president delivers. He has something very special about him. He gets the best people from anywhere in the world, to get into positions to deliver, and he makes sure that they deliver. And so what is done in healthcare is gone, you know, to all the corners of Nigeria and all the corners of the world to bring the very best. We got Dr. Sama, we got Dr. Alausa, we got Professor Pate. They are the very best you can think of. They have excellent track record from Maiduguri. You can see the track record of Dr. Sama. You can see the track record of Professor Pate. So I believe that my principles are not going to talk about theory. They have seen all this, want to make a huge difference. And I just permit me to say a little about clinical governance. There's a reason he talked about leadership. It's essentially about leadership in the health sector, a framework in which health services will be accountable for maintaining excellence of care, maintaining continued quality improvement and safeguarding the care and ensuring that this excellence will flow. So there is going to be a framework of accountability. So you don't just have people in positions who've been there. You're going to be accountable. We're going to have data, and this data will be fed, and this data, many of them will be in public domain for the first time. Okay.
So it's accessible to anyone.
Joe Kiani said, what you measure improves. What you measure openly improves even quicker. That's what we're going to do in this new government.
Absolutely spot on. All right, let's divert a little bit and talk about medical negligence as a major contributor of avoidable harm, especially in Nigeria. Why do you actually think that in 2023 we still have this spike or surge in medical negligence, despite the advocacies, despite the complaints? The last time we had this conversation about World Patient Safety Day, we had someone who came, a victim of medical negligence, who talked about how her son was how he had cerebral palsy, which was avoidable, which was preventable, but because of due to the medical negligence, that's why they fell into that trap. So why are we still talking about medical negligence, and how do we curb this menace?
Thank you very much for that question. First, I have to say my heart goes out to that lady and her family, and indeed all patients that have suffered harm in our health service. It's a terrible. Even if it was one, it's one too many. We don't want it. And this is the reason why we're here today, that I want to focus our attention on this problem. It should not be swept under the carpet anymore. We talk about, it's a massive problem globally. About 135 million people are harmed in care every year, out of which about 2.6 million die. And 15% of budgets in low and medium income countries are used to treat complications. That is unnecessary. These are things that could have been put into better care. And we all know that for inpatients, at least 1 out of 10 is harmed. Out of these, up to 1% have severe harm or die. About 6% have, moderate harm. About 24% only have low harm. It's only 69% that go into hospital, nothing broken, nothing missing. That's terrible.
Terrible.
Okay. The fear of surgery also is real. That about 50% of those cases occur in the perioperative period. But the best part of the story, the reason why we're here today, is that 50% are wholly preventable if we can follow the guidance and the protocols. If we have a system in place like the policy we're having, we have a guidance set up for the facilities, and then we have a monitoring system, that 50% are wholly preventable. It's because of that assurance that we're going ahead doing all these policies, doing the strategy document, and making sure they are fully implemented, and making sure that we are going to collect data according to Professor Pate, and we feed the data in, and we will continuously improve care in this country.
So now, because you talked about collecting data, especially from the grassroots, so let's go back to those grassroots hospitals. How do we actually avoid that medical negligence? Some people will tell you that it starts from the auxiliary nurse. some people will tell you, if I go to a hospital and I see any nurse putting on blue, I just walk away. So how do we avoid this harm, especially from either the interns or the doctors or the auxiliary nurse?
Thank you very much. There are several types of harm. When you say harm, there are several. It could be perioperative harm. It could be harm as a result of diagnosis. It could be medication harm. It could be infection prevention and control harm. Let's just take the example of surgical harm, perioperative harm. Okay. You've heard of, really at the extreme end, you heard of things like wrong side surgery or foreign body, a foreign body left. There are protocols in place to deal with this. The problem is that people are not following those protocols. Okay,
sorry, I had to body. You said foreign body left, like when you hear stories of scissors or something left in the person's...
Yes.
Okay, go ahead.
Okay, so wrong side surgery is a horrible thing, and we have recognized this, and we call it a never event. That's an event that should never happen if the existing guidance are followed. And the existing guidance are there, that you have a consent, a valid consent. That's I have to explain to you what patient. It is, and you give your consent, and then I have to mark the area before you're allowed into theater. And before the surgery starts, the team will have that huddle, team brief. And then there will be a signing. There will be a timeout even before the knife touches the patient. These are standard policies, guidelines. The World Health Organization Surgical Safety Checklist was first developed in 2008. I've taken it around this country from Lagos up to Bauchi to Calabar, Port Harcourt, and straight to the other end in Sokoto to ensure that these become a part of the practice. And I'm pleased to inform you that these are being taken on board. The Nigerian Society of Anesthetists have done very well with them. The Society of Gynecologists of Nigeria, I've also met with them in Calabar. They're working also on the maternal early warning scores. All these protocols, guidance, are necessary to support frontline workers. Frontline workers should not just use their opinion, not just work based on how they feel. And that's part of the problem. But you see, whether they do this or not, you need somebody who is accountable. That's why clinical governance is key. And that's why Professor Pate is, making that a very major part of his agenda.
All right, so because we always take messages from our social media corner, I will take this one. Says, I'm coming from someone, he said, I honestly don't know how to feel right now. Negligence, mediocrity, I don't know, but I am sure it has nothing to do with misery. I've always thought that I was AS, as all of my siblings are. Took a genotype test when I got admission, and the result was AS as predicted. All my life I've shaped my life decisions around that knowledge, but last week I was at the hospital to visit a friend, and case of mix-up genotype came up. We all had a long discussion about it, and out of jokes and bands, one of my friends realized that he doesn't know his okay, so let's just jump. So he said, so I decided to take the test again for clarity's sake yesterday. People of God, I just got my test results tonight, and I'm here staring at my AA genotype. I honestly can't deny that I am disappointed right now, because according to him, he said that was the reason why he lost his potential relationship. Because I hear you talk about diagnostic errors. So how do we deal with this? From where do we start if we have to create punitive measures so that this trend doesn't continue?
Thank you very much. I'm very sorry to hear that. Really sorry. We need a governance system, a robust system. You see, you shouldn't be able to just open a lab. You should be registered, and there should be quality control to enable you carry on with your license. And that's what happens. That's the standard practice. Unfortunately, that has not been enforced. So you have a lot of people setting up laboratories, setting up ultrasound centers who may not be appropriately trained. So like we said earlier on, whilst we want to support the doctors and the clinicians and empower the patients, one way of empowering the patient is to make sure they can ask questions like this, and we have a regulator, an independent regulator. Independent regulator will make sure that these organizations cannot exist if they don't meet the rules. The standard rules is that you have a quality assurance process. You know, you'll be able to check your results to make sure they're right. You don't use equipments that have not been calibrated and generating results that are creating problems, and people are starting medications or treatment regimes on patients that do not need the treatment. Yes.
Okay, so before we go on this quick break, as a patient, how do I know if I have to walk into a laboratory to get tests? How do I actually know that this lab is not licensed? What are the first pointers I should look out for?
Pointers may be deceptive.
Ah.
Yes, and
Okay.
this is a concern. Some of the finest hospitals may not be the best. And some of the hospitals that are not looking as beautiful outside may actually be the ones that are working ethically. Because, for instance, we go back to surgery. Where the surgery is actually taking place is far deep in the theater, you know, and nobody really goes there, except you have a right to visit that place as a regulator. So you don't know. You can have a beautiful reception area with all the fine things. You have lovely car parks with great cars there.
And probably a pretty receptionist.
You know, but the operating theater might still be using anesthetic machines that have been discontinued many years ago.
Oh, wow.
You know, the laboratory or radiology may not be up to standard. So yes, it's very, you see, this is a problem. People go out and want to go to the most beautiful place. But unfortunately, that beautiful place may not be all that it is. I think this is one area that the government is taking seriously, that we do need a regulator.
So I hear you say that all that glitters is actually not gold.
Yeah.
All right, so clearly we have so much to unbundle from this conversation with Professor Asekhame Isemede, and we will get right into it after this time out. Join us again.
I am pleading to hospital management. Funding has already been allocated for about 10 people in a department. There are now 8 people. The 8 people doing the extra job should be given that extra pay.
Okay.
Because if you're overworking people, you should pay them more.
I hope that happens.
No, I think that should be straightforward, because the stress is going to be too much on them and people will break down, and then the system will suffer.
If you just joined us, this is The Conversation. We're reaching you from KAFTAN's television studio here in the nation's capital, Abuja. And if you just joined us, you've actually missed out on a whole lot. But then you can still join in the conversation, as that's the good news. My guest on the show today is Professor Asekhame Isemede, who is Director of Patient Safety Africa. All right, before we went on that break, we've actually dealt with quite a number of things with regards to medical negligence, World Patient Safety Day and all. Now let's delve right a little bit again and talk about maternal mortality rate in Nigeria, especially in 2023. Why is Nigeria still recording a high rate with regards to maternal mortality, and how do we cope this? Because we cannot keep losing our mothers and our children to one excuse or the other. What's the way forward?
Thank you. It is really a big concern that our maternal mortality is still high, and some parts of the country are still recording maternal mortalities around 500 per 100,000 live births. That is unacceptable, totally unacceptable, despite the huge resources that we have. But you know, before we rush into those numbers, we have to look at the contributors to maternal mortality. What are the issues? You know, the issues start right way back in the families and in the community.
Oh, really?
Okay, yeah.
Okay.
Delays in seeking help. Okay, delays in reaching help, and the delays in having the appropriate treatment. Okay, a lot of concerns around where people live and how their fear of coming to seek help in the appropriate places. Okay. and the delays, logistical delays in terms of emergencies, and that is made worse by the rainy season and what we have seen right now. So I'm afraid these logistical delays will get worse before they get better.
Oh, wow.
And then, of course, you have the delays in getting definitive care, where a lot of the focus has been all this time. Unfortunately, most of our big hospitals tend to be treating complications rather than actually preventing it.
Oh, wow.
So, in the 4-point agenda, Professor Pate talks about improved population health outcomes. Again, we're talking about data that will track all this, look at various solutions at various ends, starting from the very community, starting from the sisters, the family, you know, the local area. Then before they get to maybe the general hospital, and for the very high-risk patients, how we can fast-track them straight to the teaching hospitals. Cases like pre-eclampsia, eclampsia, where they need to go straight to where you have intensive care. The problem right now is that you don't have a track and trigger system whereby you know who is really sick, who should not be there, because in an hour's time, this patient might fit. That's have an eclamptic fit. And you don't treat that in a small hospital. You fast track this straight away. So, yes, we are going to focus not just on the complications we are collecting in the teaching hospitals right now. We're going to go further down the line to look at the community level. So what we are thinking of, and I hope the government will accept, is that, you know, the current system where you have the teaching hospital, I've been to a state, I tried to support them, have about 12 consultants in the university teaching hospital in this part of town. You have only one consultant in the state working in the general hospital.
Oh, wow.
So why is that so? And I don't think we can change that immediately, but it's something we can do. We can get some of those 12 consultants to have 75% of their time under the federal government of Nigeria in the teaching hospital, because they prefer the federal, you know, structure to become a professor eventually, okay? And 25% of the time under the state government. So they will work for the state government and support the medical officer in the villages in the care of these women. So they are involved both in the curative and the preventive side of maternal care. They'll be responsible for this woman right from the time she steps out from her house in the local maternity to when she reaches the teaching hospital.
Oh, wow.
And I believe this will help rather than waiting for the patient, you know, when she's already collapsed, to be treating her in our big teaching hospitals.
Oh, wow.
This is one strategy. But I tell you, I'll just take it back to about 1937 in England and Wales. Something happened. This was quite dramatic. There was a study carried out and was published in the American Journal of Nutrition. It was published in the American Journal of Nutrition because the people set out to look at maternal mortality during the wars, you know, First World War and Second World War. And they thought maternal mortality was going to increase because there was rationing of food and things were really bad in England at the time. But what they found was outstanding. They found that maternal mortality in England was running around where we are now, 80, 90, and bouncing, not making much difference. And then 1937, there was a dramatic fall. And often when I ask people, what do you think happened here? Was it blood transfusion that set up at that time? Was it penicillin that was introduced to deal with infections? Because blood transfusion, we have, you know, postpartum hemorrhage, infection, preeclampsia are the big hitters for maternal mortality. And some people will say it's blood transfusion, antibiotics. Some people will say it's the NHS in England. That's free health care. Unfortunately, none of the above.
Ah, okay. So what exactly was?
It was policy. Policy. That's what we're doing this week. And that's the instrument Professor Pate is going to use to make a whole lot of difference in maternal mortality. When I show you that graph, it's outstanding. That policy is bigger than all the medicines, all the CT scans and everything. So before antibiotics came into general use, before blood transfusion came into popular use, and before
penicillin,
before the free health service in England, maternal mortality started nosediving. And when the USA looked at our figures, they copied that policy, and the policy was simple, that every pregnant woman in England and Wales need to be cared for, somebody will be held accountable for the health of every pregnant woman. So they will see her, take her pulse, do the very basic things. And I've just told you that there was no blood transfusion, no antibiotics, and yet maternal mortality fell. So this is what we're trying to do in this country, and we really believe that this will make a difference.
Okay, so Professor Sonny, you seem to be very enthusiastic with regards to how far this policy that will be rolled out will definitely put a drop to maternal mortality, especially in Nigeria, and then the healthcare challenges that we're going through. Yeah? You seem to be very optimistic about that.
I have to. I'm not just alone. I have a lot of people here. I have a lot of excellent doctors. I have a lot of excellent nurses, laboratory staff all around the country who I know are very, very dedicated. It's not just my vision, it's the vision of all of us. And we will not disappoint our patients. This government will live up to expectations. I'm
sure that's what Nigerians are waiting to hear. Now, because you've taken a cue from where you landed on what you talked about with regards to why you have more staff in the teaching hospitals but less in the state hospitals or the general hospitals, let's talk about Nigeria's health care practitioners or the workforce. And now we know that Nigeria is losing zillions and thousands of its finest doctors and health workforce to brain drain. I recall having a recent conversation with the NMA president, and he blamed it on remuneration. He blamed it on training. And then same challenge I've heard you also opine with regards to training, adequate staffing and all. But then these things keep happening. So, and I also recall having a conversation with the president of the National Association of Resident Doctors, that's NARD, and he said that we hope that we don't at some point open our hospital doors to quacks, just in probably meat butchers in the name of surgeons, because with this exodus of doctors, it keeps getting worse. So what is the way out of this quagmire, Professor Sonny?
We are concerned about the challenges of health workforce in Nigeria. I have to be honest with you, there are no quick fixes. Okay, that's my starting point. But there are a few things we can do. And we believe that the best strategies are the strategies that are pragmatic, looking at the real situation. We're now in a globalized world, and the pull and the push factors have to be managed. People want better training. Okay, we need to be able to offer them better quality training. They want to have the right equipment in the hospital. The government should take that seriously. They want better remuneration, and they're not asking for too much. My doctors, my nurses need to live a decent life, just like any other Nigerian needs to live a decent life. And I'm all for, when I see people around how they're struggling, I totally support people who support, the request of people that are asking for a little bit more. And I think the government, I will add my voice to it, that, workers in Nigeria need a little bit more to be able to cope with the, cost of living. There's a cost of living crisis going on right now. And that cost of living crisis, not just for doctors, not just for nurses, but for everyone. Drivers, cooks, everyone is going through that. Okay. And except you fix that, you're going to have an exodus of those who are more able, who are more attractive in the international arena. One of the problems is our success. Our success of Nigeria. We are a Commonwealth country. We were trained in English language, and we use the same books that they used in England. And what has happened is that if you excel in Nigeria, you're very likely to be good internationally without having to struggle to change language. So our medical schools will bring up, doctors who will become very accepted, very well accepted in most parts of the world. So that's there. And nurses, the same thing. What can you really do about that? Are you going to shut them in? Can somebody shut, the WTO Director General in here because we just want her here?
For ourselves.
It's impossible. Can we shut in Professor Pate here, without having to have all this international exposure? Can we shut in somebody who is playing for Chelsea in London because we want him to captain football? We cannot do that, but there are a few things we can do. These are the exceptional cases, very top and the top. So I don't like these rules, these laws that people are going to sign. They say we don't want international, we don't want anybody, our doctors to go abroad, our nurses to go abroad. We're shooting ourselves in the foot, and I really am serious about that, because it's when you let your best go, they come back. Look at India. They come back. Nobody has paid me to come back here. Nobody's paying me to come spend part of my time in Nigeria. It's just a natural thing. Not everybody will come back, but majority will come back. And when you come back with something which money cannot buy. Okay, so it's complex, and I want us to look at those factors. There are simple strategies to help in the training. Obviously, we need more funding, but there are a lot of doctors in the diaspora who have reached the top of their game, who are able to support e-training system. And they can support the training at the postgraduate medical level, at the hospital level, can spend 2 weeks here or online. The other point I quickly like to point out is this, that where are these problems mainly recorded? They tend to be recorded a lot in the teaching hospitals. Okay, but there are simple things we can do right now. Take, for example, a top teaching hospital like University of Benin Teaching Hospital, University of Lagos, Ahmadu Bello. Okay. For a position of a senior house officer or registrar there are at least 20 qualified doctors for that interview spot. So one will be taken, and the other 20 are out doing other jobs. When this one goes abroad, why do we wait 6 months or 12 months to have another interview? So that's something that can be quickly done. You can go straight away in the next 1 month to just find out who is next in line. The next in line is probably in one small private hospital. But it's not being called upon, and they're waiting, going through a lot of bureaucracy for 6 months, 12 months to call for another interview. And then lastly, for those who are left behind and having to take up the job of others, I am pleading to hospital management. Funding has already been allocated for about 10 people in a department. There are now 8 people. The 8 people doing the extra job should be given that extra pay. Okay. Because if you're overworking people, you should pay them more.
I hope that happens.
No, I think that should be straightforward, because the stress is going to be too much on them, and people will break down, and then the system will suffer.
Even when they still keep complaining that they've not even gotten their COVID-19, what was that? What was the name they called? I think it was the emergency fund, 5,000. We just hope that these things is being sorted out soon. Let's delve right a little bit again and touch on other matters of serious concern still on health, Nigeria's health sector. But this time, let's talk about surgeries and emergencies. But then let's begin with the surgical care. At the mention of surgery, especially in Nigeria, most patients just go cold and begin to shiver. Because I recall while growing up, there's this particular hospital in Lagos, I'm not going to mention name, where patients, whenever they're taken there, their only solution is cut off, amputate immediately. So, and then I'm wondering why we still have so much fear around, even in 2023, shrouded around surgery. What's the way forward? 2 questions, and I'd like you to unbundle them in one breath, even as we begin to round up. Now, that's one on the side. Now, and then let's talk about high rate of emergencies. You find in our hospitals, every hospital you visit, the emergency wards are completely filled up. What gives, Professor Sonny?
Thank you very much. The fear of surgery is real. I was sharing some slides earlier on during the conference, 1 million, about the burden of surgical harm around it. What is quite frightening when you quote the figure, and I don't feel very comfortable quoting the figure really, but the fear of surgery is real. But there are solutions, and there are simple solutions.
Okay. So
we have examined all the problems that occurred in all these surgical. A few years ago, a study was done. I found out that about 230 million patients undergo surgical procedures every year, out of which about 3.4% have complications. 3.4% turned out to be 7 million. Complication could be infection, could be delays in discharge, could be severe pain, could be simple things like, well, I don't like to call anything simple. But I don't like to call anything simple. It could be delay in giving medication without having serious harm, or it could be severe infections and having to have a delayed discharge. And then about 0.43% died. 0.43% of 230 million is 1 whole million. When this was published, people rubbished it and thought it was academic. It wasn't. It was evidence-based. 0.43% of that 230 is 1 million. And we broke this down. We found out that a whole lot of the issues can be prevented, at least 50%. I've said earlier on, 50%. What are the ways? Ways are simple guidelines. This is what we're doing differently this time. So we're not looking at 1 million mortalities. We're breaking down, why did this patient get a post-operative infection? Okay. Why was blood not given to this patient at the right time? Why did this patient become anemic? Why did this patient have a complication associated with renal failure following this surgery? Okay, so we break this down and use simple rules, starting from consenting. I told you earlier on, starting from marking the right side, starting from having a huddle before the procedure, starting from making sure the whole checklist is already there, and it asks you, have you got antibiotics here? Have you got the right, oxygen monitor for this patient? Have you assessed this patient, for allergies, and it should have the right wristband on the patient. How much does it cost to put a wristband? Why would, patients, we did a study and found out that only about 25% of patients, have, proper identification band them. 25%. And all these hospitals, they do surgery. All these hospitals give blood transfusion. Are you giving blood to somebody you can properly identify? You're giving blood, you are operating on a patient who will go under the anesthetic, and when the patient wakes up, how do you actually do this? So a lot of those complications can be dealt with the very simple things. It doesn't require much funding from the government. It's very easy to say, oh, the government has made our hospitals consulting rooms. But it doesn't require, what does it require for you to put an allergy band? What does it require to do you know, a site marking? What does it require you to do?
Have consent.
Just wait another 5 minutes, have a chat, find out who the nurse is, find out if the nurse knows the equipment you want, find out if the equipment actually exists. Don't start the operation and then begin to ask for an equipment that does not exist in this country. So simple things like that. These are the guidance that we have. This is what we believe would make the difference. We have gone around hospitals to train people on this, but it hasn't really happened because we've only trained the staff. Except the medical directors and the chief medical directors take hold of it and are responsible, accountable for it, it's not going to make the difference. This is why Professor Pate is talking about clinical governance, that accountability framework.
And does this also touch on the private hospitals or just the government-owned hospitals?
Oh, private hospitals will be involved.
Okay.
Yeah, as long as in the Federal Republic of Nigeria, they're covered. So they'll have to show evidence that they're doing it right. It's by insisting on these little steps that will prevent the bigger things. That's about surgery. Going to emergencies, you know, surgery features a lot in emergency care. Unfortunately, many of our big hospitals are treating complications and emergencies. The reason is preventive medicine is still not taken seriously by people. There's a whole lot of work done on that community medicine and public health, but we still do them in the offices, we still do them in the clinics. I think the time has come for us to take our nurses, our healthcare assistants, or our community health officers to the marketplaces. Take the blood pressures of these people, do the blood sugar levels, you pick up the diabetics, pick up the hypertensive, and move them to hospital.
Just like we did during the polio, where they had to go to houses, knock on doors.
Absolutely. Rather than waiting for people to have a stroke, and then you spend a lot of money and you move them, you have one scan after the other, another scan. So this is why we have so many emergencies, because the preventive aspect is not taken seriously by our people. The government is spending a lot of money on preventive medicine, but we need to fine-tune that strategy.
All right.
And I'm very happy that Professor Pate used the word population health outcomes.
Oh, wow. So we've actually overshot our time. But before we let you go, let's get your last words to not only the hospitals, not only the government or the CMDs and the MDs. Let's also get your last word to patients, even as we commemorate World Patient Safety, not just day, week, month, every day.
Every day is Patient Safety Day. This day was just set aside for us to talk about it. That today is a very special day because we want to cement that relationship with patients, which is a relationship that is going to go on every day, engaging them for patient safety, telling them that we hear them and we hear them very, very clearly, and that things will not remain the same, and that the system will change. First, I also want to appreciate my doctors and my nurses and all the healthcare workers. They don't go to work to want to harm patients, and that has to be clear. And I also want to make it very clear that we have a zero tolerance on violence against our staff. We're going to support them. But today is that of patients. It's a very special day, that this patient will no longer be the edge of care, begging to be served. That you are the boss, you are going to be the heart and in the very center of care. Thank you.
Professor Sonny Isemede, it's been a wonderful time. Like, we could just actually go on and keep discussing this matter. Thank you so much for your time with us.
Thank you.
All right, I'm sure you have been rightly educated, entertained, and informed. We have been chatting with Professor Sonny Isemede, who is Director, Patient Safety Africa, and it's been a wonderful time here on The Conversation. I will see you next time. Like I always tell you, ensure that you stay safe. Until I come your way again from the nation's capital, Abuja, I am Annabelle Oji. God bless you and yours, and God bless Nigeria.